And along those lines, what kind of supplements and stuff are out there that you may tell people not to take? So, what I mean by that is, I see a lot of patients on like T boosters, test boosters.
So most of those actually don't do anything for your testosterone at all. So a lot of the weightlifters are on testosterone, and you can't take testosterone. Testosterone will drop your sperm count. It's actually being used as a contraceptive. Those are the things to avoid. Those other ones which you're talking about, which they describe themselves as testosterone boosters, they don't actually have testosterone in them. I would still tend to avoid them. You're worried about contamination, so avoid them at that point.
Welcome to My Fertility Podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together. Today's episode of My Fertility Podcast, we are joined by Dr. Keith Jarvi, who is a professor of surgery and the head of urology at Mount Sinai Hospital in Toronto, Canada. He is the director of the Murray Koffler Urologic Wellness Center at Mount Sinai Hospital, which is the largest male infertility clinic in Canada, and is working to develop less invasive ways to identify and treat male infertility. His other main clinical interests include microsurgical reconstruction techniques, sperm retrieval techniques, and genetic abnormalities. We are joined by an absolute leader when it comes to male infertility in all of Canada. Check out episode 44, where we spoke with Dr. Jarvi about the semen analysis and sperm DNA fragmentation in detail. In the previous episode with Dr. Jarvi, we talked a lot about the semen analysis and all the different parameters and all the things that we're looking for and what it all means. So let's say we get a semen analysis report back and, the count is a bit low or the motility is a bit low or both of them are a bit low. How can we improve sperm for fertility?
Yeah, I mean that's the core to this, right? So if you look at couples coming through, at the end of the line, they want to conceive. And whether or not you treat the male, treat the female, both, it doesn't actually matter. Their goal is to have a child. Because we're just talking specifically about the male. A lot of times you have to talk to the couple to find out what their goals are. And so if a couple come in, sperm counts are say a little bit low, but she's 41, you may decide that, in fact, there's really nothing you want to investigate for that man whatsoever. It's quite legitimate to just jump right to something like in vitro fertilization, which offers a couple quite a good success rate without actually investigating the man. I'm a urologist. I just said that. Okay.
I mean, we agree, but we're a little
Yeah, I
biased.
agree.
Yeah.
But you have to approach this as a couple. Their goal is one thing. The urologist's goal is to try to improve the sperm quality. I think of it as trying to improve the sperm quality, trying to identify underlying issues that may be risky for the man's health in general, and then trying to avoid IVF if possible. Okay.
Mhm.
Because IVF is something you want to avoid, but maybe IVF is actually the best choice for couples. But generally, you try to avoid it, IVF. Okay.
Mhm.
So if you have a couple coming in, generally with a low sperm count, the goal here is to try to find something that is reversible in this. First of all, you have to prove it. You need 2 sperm tests at least to prove it. And sometimes a third just to prove it. Then we go through looking for things that are like lifestyle issues. We look for evidence of infections, hormone problems. We're looking for anatomic problems like varicocele. We're looking for maybe something where, again, lifestyle heat, something which causes heat around the testicle. There's a whole series of things that we look at to try to identify something that we could do to improve the sperm quality. And there's a lot of things in there. And you can start with the easy ones, like supplements you'd probably be given to most men, even though it's sort of controversial as to how much. But then you're thinking about things like varicoceles, which are the most common cause of infertility in men, occurring about almost 40% of men with infertility have a varicocele. So it's a pretty significant number. And then we're looking for things like infections. Infections are quite well treated usually, and looking for hormonal problems also. So those are sort of the big buckets of things that we're looking for. If we're looking at that, we're also looking for health risks for the men. So men who have infertility have higher rates of testicular cancer. So we have to make sure they examine them well to make sure that they don't have any evidence of testicular cancer. Okay, so that's actually very important to measure. So as the sperm counts go lower and lower and lower, then we start to think about genetic causes for this infertility, which may potentially be transmitted to a child. So then we're starting to think not only about, things that improve the men's fertility, but also as the counts go lower and lower and lower, we're thinking about things which may be transmitted to a child. So you think of the risk to children, but again, as the counts go higher, the risk to children probably lower. Counts go lower and lower, more and more you're worried about potentially transmission of something to the children afterwards.
Can you comment on the actual numbers when you say high and low?
We generally use a cutoff around 5 million
Thank you.
as very low. Between 5 and 15 million is low. And under 2 million is considered to be very low.
And is it at the 2 million or the 5 million where you start doing things like karyotype and testing for CS and testing for those genetic conditions like white microdeletions that can have an impact on a future child? Is it at the 2 million cutoff or the 5 million cutoff?
So you start worrying about it about the 5 million cutoff, and then you do the genetic testing, and depends upon the characteristics of the man. Sometimes you do cystic fibrosis testing. Sometimes you might do Y microdeletions. This is a test of a little small part of the Y chromosome to see if it's missing, and that's higher. And a karyotype, which is the general roadmap for men's genetic makeup. We're looking for big pieces of the DNA that are missing, or maybe they're moved from one gene to another gene, something called a balanced translocation, which also can occur in women too, but it's quite common in men who have infertility. You can actually have that occur in about 1 out of 30 men with a low sperm count. So that could be quite an important finding for men.
Mhm.
So lots to unpack there in that answer. Lots to go over, lots that I want to ask you about. Let's start off with diet and lifestyle. How do you counsel about diet and lifestyle, or what lifestyle and diet factors are negatively affecting sperm, or what can you do to improve sperm?
Yeah. It's kind of interesting. I always found that the dietary and lifestyle factors for fertility almost match the Canada Healthy Food Guides and the recommendations. So it's like the testicles are, the canary in the coal mines. The canary
Yes.
better get out of the way. Sperm count goes down. This could be an indication of something else that's affecting the rest of the body. We really try to almost follow the Canada Healthy Food Guide. So standard things like reduced red meat consumption and fruits and vegetables, Mediterranean diet is recommended. But these are almost always the same things that are going to keep the guys healthy and alive longer anyway. So I have no compunction about recommending that at all for the patients. Smoking is obviously a big one here. And then weight control. So even if you're losing 2, 4, 5% of weight, you can actually improve the sperm parameters fairly significantly. I don't go about weight control trying to lose massive amounts of weight, but even small weight losses in those who are overweight may have a significant impact, positive impact on sperm parameters.
Can you comment on marijuana use since we're on the topic of lifestyle factors and sperm?
It's a harder one because there are not a lot of studies on marijuana and male infertility, to tell you the truth. A lot of the studies were done on men who are using a lot of marijuana. So we don't actually have a lot on those who are using it socially and only in minimal amounts. I've been recommending that the men stop it because that's usually very easy for them to do. And with the idea that I can't necessarily prove it, but back to the whole idea of, this probably can't hurt you by stopping. You can go back to do what you're normally doing in 12 months. We're going to do everything in the next little while to try to improve it, even if it's not necessarily 100% proven that that's effective. So I suggest they stop it.
And now let's talk about supplements. What are the supplements that you recommend? And if people are going to just go and buy supplements on their own, what should they be looking for?
There are a number of supplements that are being sold that you can buy that actually have some good components on it. What you're looking for in the components is like CoQ10 is a fairly common supplement that's being used, which has been shown to improve sperm motility on average. It doesn't necessarily work on all men. And then there's some evidence also that it might decrease the DNA damage rates. Acetyl-carnitine is another one, but you have to use a lot of it to actually have the impact. And even things like vitamin C and vitamin E, which are pretty commonly available, are also have pretty good evidence that they improve the quality of the sperm. So I think a regular supplement, if you look at the kinds of things that we just mentioned, and there are a lot of supplements out there that have that already in them, I think you could do fairly well. They're relatively inexpensive. And my view with supplements is there's probably some men where it's going to work and some men where it's not going to work. But it's one of these things that probably can't hurt you as long as you don't overdo it. So I think in order to affect, about half the people, the other half are going to use it and not have any benefit. So it's going to benefit some men, but it doesn't benefit everyone. I think going into it, patients should recognize that this is low risk.
And along those lines, what kind of supplements and stuff are out there that you may tell people not to take? So what I mean by that is, I see a lot of patients on like T boosters, test boosters, and other kinds of things like that.
So most of those actually don't do anything for your testosterone at all. If you're offered by your doctor or in the gym, so a lot of the weightlifters are on testosterone, and you can't take testosterone. Testosterone will drop your sperm count. It's actually being used as a contraceptive. So those kind of gym weightlifting and kind of things you should avoid. Okay. Those are things to avoid. Those other ones which you're talking about, which they describe themselves as testosterone boosters, they don't actually have testosterone in them. I would still tend to avoid them. You're worried about contamination. So, avoid them at that point. Let's put it this way. If it's healthy for you, it's probably good at the end of the line. So you try to avoid the weightlifters kind of things because you're always worried about testosterone being somewhere in there. Maybe it's a contamination or maybe a deliberate contamination. Otherwise, most of those supplements are probably okay for you. You have to look at each individually.
And just to clarify, by weightlifting supplements, you mean like the stuff that you might sort of buy from like your friend at the gym, but like something like a protein powder, creatine, like something that you might buy at a health food store.
Thank you very much for correcting that. Yeah, I'm more worried about those kind of things that you might get in the gym from
alley, maybe behind the
alley, right? Where the description may be that it's just a supplement that you can take, and it actually might have something which is testosterone in it. Mm-hmm. So you could buy those exercise supplements from those very standard locations. Those should be safe. Again, you're quite correct. I was more worried about the ones where it's not regulated and you're not 100% sure what it is, and you should always avoid testosterone.
And that's so interesting, though, because that's not a very widely known fact. I mean, I have seen many patients, I'm sure Dr. Garcia, you've seen lots of patients, where men have been prescribed testosterone, maybe they've been taking it for years, and then they come see me and they're like, they have infertility. And, we immediately have a very good idea as to why, but it comes as a shock to them.
Yeah, you're right. Now, the people who work out regularly, they're actually pretty familiar with that effect. And some of them are actually going off it in cycles in ways. I don't know that this is something we should talk about or even endorse because they should just avoid it, period.
Yes. Yeah.
Literally.
It's not under control. You're getting something which you never know what you're getting, and you don't quite have control over it. Yeah.
Mm-hmm. So one of the things you brought up when you are looking at somebody that has low sperm counts or low motility is doing an ultrasound to look for varicoceles, which you explain are swollen veins around the scrotum. Can you talk about the treatment of varicocele, what it's involved, how invasive it is, who should have the treatment done, and what kind of improvements are you expecting to see after a varicocele repair?
Excellent. Yeah, really important question. This is the most common condition that we have in men with infertility. And some men will tell you that they have like a bag of worms feeling above the left testicle in particular. They feel it's fuller. And what actually is happening is those veins, which normally take blood back from the testicle towards the heart, and they have little valves that only allow the blood to go in one direction. Those valves have been damaged. So if the men push down or stand up for long periods of time, blood is pushed back towards the testicle through these veins. And as it gets pushed back, those veins get bigger by pressure. And that's when the men feel that little fullness at the top of the scrotum. And they can actually make it bigger if they stand up. So we make that diagnosis by fingers or by ultrasounds. Okay. So the whole goal of any procedure to fix this is to fix those abnormal veins that have those valves that are abnormal, that let the blood go back down, block those veins off. So there's really two most common ways of doing that. One, they could use a vein in the neck and they track down through almost like a Venus highway down to the veins to the testicle. And then from the inside, they usually leave a little coil on the inside, which blocks the veins that are abnormal on the inside. Okay. The other way to do the same thing is to make a cut about this big, just over where the veins are, right down in the groin. And with a microscope, you can look at the big veins and then you tie them off. It has exactly the same outcomes. You're blocking those abnormal veins. What you're doing is you're leaving the normal veins. The veins that have the normal valves are left alone and they continue to drain the testicle. So you're not taking out all the veins, you're just taking out those abnormal veins. And what happens then is the testicle actually gets a couple degrees cooler. There's less blood around the testicle. It actually has better blood flow to the testicle and it cools off. And as it cools off, it's the same thing that we were talking last time about the scrotum cooling. As it cools off, then the sperm quality goes up. So the question is, how much does it go up? Because if you know how much it goes up, then you could start talking about who should have it. So if you have a man coming in with a sperm count of, say, 10 million, and on average, about 70% of the time, with this repair, the sperm count will go back to normal after this. And then the couple will have almost a 60% chance of conceiving if that's the only thing you do. And she has to be, say, 35, because if she's 37, 38, 40, you may not have the time to wait. As you pointed out previously, timing is critical here. The longer the women wait beyond a certain age, the pregnancy rate drop per month. So you may gain by increasing the sperm count, then you lose by the age. That's something that you have to factor in. But let's go to the same couple. So starting with 10 million sperm count, very viable to do the repair, no matter which way, either way. But let's take the same couple and you're coming in with 1 million sperm. So after 1 million sperm, you may expect them to go up to around 3 million. And the three of us right here would know that if a couple came in with 3 million sperm and nothing else to do, they should go to IVF right away because there's nothing else that you can do. Waiting around is not going to benefit those couples whatsoever. But if you start with 1 million sperm, that's probably enough for IVF. So you're probably not changing the outcome by offering that man coming in with 1 million sperm a varicocele repair, because at the end of it, he's still going to need IVF. And then you're wasting 6 or 9 months of time during which the partner's fertility is starting to go down. So a tricky question. We generally think of it in two ways. One, how much can we improve the sperm count? And is it going to make any difference to the couple's chance of conceiving at the end of the line?
Now, in that argument, would a varicocele repair improve DNA fragmentation, though?
Yes, that's the other argument. So if you have other things going on where the IVF success rate is going to be lower, then you should consider varicocele repair at that point. That's a different issue here, but something you have to factor into your calculations.
That's right.
Yeah,
that's right. So, I mean, we've talked about sperm concentration, we've talked about sperm motility, and we've talked about DNA fragmentation. At the very beginning of the first episode, those were the three parameters that you really spoke about the most. Is it fair to say that all those three parameters respond to the same things? Lifestyle factors, supplements, the cooling. Like the approach is very similar from the point of view of lifestyle, right? For all of those three
Right.
things?
Correct. I think they
Okay.
all respond to those treatments. But interestingly, one of the largest buckets of treatment that we offer to couples is hormonal therapy. And unfortunately, hormonal therapy, very effective, but doesn't change the sperm motility much at all. Very good at counts, but not very good at improving sperm motility. So the treatments you mentioned before, across the board effective. Hormone therapy, unfortunately, not as effective across the board.
And by hormone therapy, are we talking Clomid, ACG, FSH?
They're
Hormone
all the
therapy.
hormone therapy at the end of the line is increasing the drive of the either luteinizing hormone or follicle stimulating hormone on the testicle. So there's a lot of ways you can get to that. You can use Clomid, which is the most commonly used one in Canada and North America. But there's also a lot of other ones that you can try. And it really depends upon what your baseline hormones are to decide which kind of therapy may be most effective for you.
And there is also no impact on DNA fragmentation, I assume. Hormone treatment.
Hormone treatment, yes, unfortunately, it gets more complex. With the Clomid, there appears to be an improvement in DNA fragmentation rates too. It
Huh.
doesn't seem to do much for sperm motility, unfortunately.
So, do you think that if I have a patient with a sperm count that is maybe around that 10 million mark, is it reasonable to try Clomid for a few months? I mean, assuming, of course, that the partner with eggs is younger and we have a bit of time to work with. What's your experience like with using Clomid? Because I know certainly amongst fertility physicians, it's pretty mixed in terms of how people feel about it.
Clomid is a very effective medication if you choose the right patients. You have to choose patients where you think they've got a good testicular reserve that will respond. And you can sort of look at the FSH levels. If the FSH levels are already high, they're not going to respond very well. Number one.
Right.
With
Right.
this,
And it's like a female fertility patient
That's right.
where if their FSH is high, we know that they're not going to respond very well to our stimulation medication.
that's exactly the
Yeah.
same. So then if the sperm motility is low, it's very unlikely that Clomid would benefit them. But the ones where the sperm motility is actually quite good, they do very well. The problem with Clomid is you've got to leave them on it for, 9 months to a year. And some of them are just going to say, listen, I don't want to be on it for this long. What alternatives do I have? And then you're looking at one of the assisted reproductive technologies at that point as an alternative. So I think Clomid is really a good option for couples to offer them in specific circumstances where it looks like the testicles could respond and we've got a little bit of time on the partner side and this burn quality is pretty good, but the count's low.
That's actually really interesting to me. I always assumed, to be honest, that Clomid, 3 months, like the life cycle of sperm is 3 months, right? This is what we think about, or I think about all the time. And so I assume, if someone's on Clomid for 3 months, that's going to be the magic number. 12.
No, it's not 9 months. It's 3 months to improve it, but they don't get pregnant right away. So, you're
I see. Okay.
so in order to,
Mhm.
you then have to have a 6-month window of trying to give yourself a reasonable pregnancy rate. That's all we're saying. Not-
So to start on the Clomid, maybe redo a semen analysis after 3 months would be reasonable. And then they can try and conceive. Okay, I got it now.
But if you look at that, I mean, this is all the math part of this because you think of this. So if you're going to take a year to get to that point, you might get, if you're lucky, 40, 50% pregnancy rates. If the couple want to expedite that, they go through IVF. If she's 35, the cumulative pregnancy rate for one IVF cycle is about 65%. So then you have to start doing that math and then have a full discussion about what the couple's interest would be. The fact that we can do it doesn't necessarily mean that we should do it, or is it actually the couples they're going to be telling us what they think of their lifestyle, how quick they want children.
So I'm going to put you on the spot because we get put on the spot for this question all the time. So I'm going to pass on my pain to you.
You share the pain, yeah.
Share the pain. So female partners ask us all the time, doctor, is my stress causing my infertility and my miscarriages and all those issues? So do you think there's any evidence from the male's point of view that stress has an impact on sperm parameters?
So, strictly on sperm parameters, we don't have any evidence, but certainly on the ability to provide a specimen in timely fashion. They can't provide a specimen in the morning. That's something which I think I'm amazed that more of them don't have a problem because it's such a stressful situation. People also under stress, their lifestyle breaks down. So they're not eating well, they're smoking more, they have all these other things. If you just piece out stress alone in men, I haven't seen anything which would correlate that to sperm parameters specifically.
For all the people who are listening to this podcast episode and who are trying to optimize, they'll say not even improve sperm parameters, but optimize sperm parameters, do you have any final pieces of advice or any words of wisdom?
Yeah, I mean, people don't necessarily appreciate how much lifestyle makes a difference. So they can start by following the Canada Healthy Food Guide, maintaining a healthy lifestyle and weight. I think that's actually more important people recognize. And then should go through the fertility workup. Don't be afraid of it. You know, they're there to actually try to help you and your partner conceive. And it's important that the men get the workup because there is a higher risk of having some underlying health conditions in some of the men with infertility too. So again, don't be afraid to get the workup done. It's a bit daunting for some of the men to face the fact that, yes, they may be infertile, but get it done. It's important for your health. It's also important for you as a couple to recognize that the group here, they're trying to help you as best they can.
Thank you so much, Dr. Jarvi.
Thank you very much.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media, Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramir C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.